So, acquired immune deficiency syndrome, or otherwise known as AIDS, is really a late stage disease from the progression of HIV. And so, AIDS develops as a consequence to an initial HIV infection. HIV has really been endemic since, the mid 1970s, actually. Um, in 1981, is really the first time when public health officials actually documented that there was this presence of disease that would later become known as AIDS. So HIV was actually documented to be the causative agent in 1985, even though it really started in the mid 70s. It was not until 85 that it was actually called HIV. And it was quickly becoming an endemic problem in the United States. So it was in 1987 that AZT became available on the market. That AZT was the first drug that came in 1987, again, just 2 years after HIV was signaled as the causative agent. So there's still 56,000 new cases every year in the United States of HIV in the United States. It's really still a global pandemic problem. Worldwide, there are about 2.7 million who are newly infected every year with HIV, and AIDS has claimed the lives of so many people. About 25 million people have died from AIDS, and there are more than 30 million who are actually still living with the disease worldwide. And there's still a great stigma around HIV and AIDS. People are still really afraid of this disease, even with all of the education and all of the knowledge about the disease. People still are afraid of it. Americans still believe that they can get HIV from, sharing a glass with someone who's affected or swimming in a pool with someone who's affected. There are healthcare workers who are still afraid of it. That somehow, they'll get HIV from caring from patients with their HIV. So, again, education really is powerful in that, just having the understanding of how this disease manifests and how transmission occurs. So, how does transmission occur of HIV? Well, HIV can only be transmitted under very specific conditions that allow a person to come in contact with infected body fluids, blood, semen, vaginal secretions, and breast milk. That is really the only body fluids that carry. HIV-infected people can transmit the virus within days of becoming infected. So, but just like any transmission of any bacteria or any virus, the transmission of HIV is really subject to the same requirements as any other microorganism that you can think of. You still have to have a large enough amount of the virus, so you have to have enough of a viral load, has to actually enter the host. So, if not enough virus, if you don't come in contact with enough virus, you probably won't have seroconversion occur. You have to have duration and frequency of contact make a difference as well, right? The more I'm exposed to a person with HIV, the longer the duration of the contact with the blood and body fluids, the more the increase in transmission can occur. The volume of fluid that I come in contact with, there has to be enough of it to actually make a transmission occur. So the concentration of the organism as well. A drop of blood is different than a bucket of blood. So, again, you have to have enough concentration of the actual organism for transmission to occur. Okay. It's not transmitted casually, right? So it's not transmitted through tears, sweat, saliva, vomit, urine, stool, or sputum unless those body fluids have visible blood in it or blood in it. Okay, so just shaking hands with somebody who's got a sweaty palm does not mean, shaking hands with someone with HIV who has sweaty palms does not mean you're going to get HIV from that. It's not transmitted in basic sweat or tears or saliva. So sharing a glass with someone, you can't get it casually. You can't kiss someone and get HIV. You can't get coughed on and get HIV. It's not spread through droplets. So emptying a urinal, using a toilet seat, shaking someone's hand is obviously not going to get you not going to get HIV from that. So transmission really only occurs through sexual intercourse or through exposure to HIV-infected blood or blood products, or perinatal transmission during pregnancy, at the time of delivery, or through breastfeeding. So that's really the only time that HIV is actually spread or transmitted. Unprotected sex is still the most common route of transmission. This is true for both homosexuals and heterosexuals. We began screening blood donors in 1985. So contact with blood through donation, through receiving blood, through blood donations, really less than 1% of people are infected. Again, since 1985, that has really gone down. That was a huge way that people did get HIV in the early 80s and late 70s. And then the risk of infection to healthcare workers from a needle stick is really less than 0.3%, less than 0.3%. I think the last statistic I read was something like 65 Americans, 65 healthcare workers or something ridiculous, some ridiculously low number has actually gotten HIV from a needle stick. So it is an extremely low number. HIV can be transmitted, though, to babies during pregnancy, delivery, and breastfeeding, and 25% of all infants born to mothers with untreated HIV will have HIV. So we do know, and we will talk about a little bit, that mothers who are pregnant who do take AZT and do take antiretroviral therapy can actually decrease the transmission rates to their infants. So HIV is considered a retrovirus or an RNA virus, which means it really replicates in a backward manner. So it actually goes from RNA to DNA. But like all viruses, it can only replicate once it's inside a living cell. So again, HIV cannot live on the surface of a table. It must be inside a host cell in order to live. And so essentially this virus has sort of proteins on its surface, and these proteins bind to CD4 receptor sites on your T cells. This is very important because CD4 counts are something that as a nurse you're going to monitor in patients. You'll see those CD4 counts being reported on lab values. So again, HIV only affects your T lymphocytes, so it binds to these T cells with CD4 receptor sites on them. And once it's inside the cell, it's basically transcribed into viral DNA strands using like reverse transcriptase and some other good stuff. And then these strands basically copy themselves so that once it gets inside the cell's nucleus, it will literally splice itself in half, right, and become part of the HIV virus actually becomes part of that cell's genetic structure. So the consequences of this is that all genetic material from then on that is replicated during cell division is going to be infected with HIV, which means every daughter cell that is created from that initial cell, no matter how many times that cell replicates, will be infected with HIV, okay? And so then the viral DNA is actually inside the genome, and then it's going to direct the cell to make new HIV. So any subsequent T cells that are made are also going to be infected with HIV. Okay, so again, because HIV infects human cells with CD4 receptors on their surface, it's going to target lymphocytes, monocytes, macrophages, astrocytes, and oligodendrocytes. So it has these sort of cell types in specific with the CD4 receptor sites on them that the HIV targets. Okay, so this is important because immune dysfunction occurs when CD4 cells are destroyed. Now, we have about 800 to 1200 CD4 T cells per microliter in our blood. That means that for every 1 milliliter of blood is actually 1,000 microliters. So that means that we have 800,000 T cells in our body. The average lifespan of a T cell is about 100 days. So once the T cell is infected with HIV, the now HIV-infected T cell will die in about 2 days, right? So the normal longevity of a T cell, normal lifespan is 100 days, but if it's infected with HIV, it's going to die in about 2 days. So HIV activity destroys around 2 million T cells a day, but our bone marrow and our thymus gland are able to keep up with the production of that loss for a really long time. Years, actually. And so eventually, though, this mechanism will fail, and immune problems really start to occur when our CD4 counts fall below 500. So that's very important, knowing that our CD4 counts, as long as they're above 500, for a really long time, we can maintain our immune status as competent, even being infected with HIV. But once that CD4 count falls below 500, we start to have problems, and we start to see opportunistic infections and other diseases. And then when our CD4 count falls below 200, we start to have severe problems where we have a significantly a much quicker progression to AIDS, which is going to lead to, of course, disability, furthering of your disease, and then eventual death. So in order to understand how HIV, can be in your system for a really long time, there's something called an acute early infection and sort of a chronic infection. So in early infection, what you see is viral loads are very high. Okay, so you get infected with HIV, and the body basically becomes the viral load is very high. The body rapidly replicates the amount of virus very quickly, right? The HIV virus has a host. The host is fairly healthy, and so it can start replicating very quickly in those first, couple of days that you are infected with the HIV. So you see a very high viral load initially, okay? That viral load after, a couple of months will drop off, and you will have a very long, steady state. So even though HIV is still being, even though the HIV replication is occurring at this very constant, rapid rate, for many, many, many years, your viral load is very low because your CD4 counts are still high enough to sort of make keep the body from still replicates CD4 T cell counts can still be replicated very quickly. So in a normal immune response, foreign antigens basically interact with B cells and T cells, right? So in the initial stages of HIV, these cells respond and function normally. You get infected with the virus tries to get into your T cells and starts to replicate. B cells make HIV antibodies that help reduce the viral load. So just like any immune response, you have this virus, your T cells start to become infected with it, but your body's B cells recognize it as foreign and they make an antibody against it. And that's what helps drop the viral load after several weeks. And that's what keeps the viral load fairly low for a really long time. So diagnosis, at the time of diagnosis, what you're really looking for is the presence of HIV antibodies. If you have HIV antibodies, that means you have seroconversion. That means that you have HIV infection. Your CD4 T cell counts are likely to be high. They're still likely to be between 800 and 1200 cells per microliter, and your viral counts are expected to be high in the beginning. Okay, so you'll have HIV antibodies tested, you'll have a CD4 T cell count, and you'll have a viral load drawn at the time of diagnosis. So undetectable viral load does not mean that you're negative and that you don't have HIV. It simply means that the level is less than the test can report. So you've probably heard of people who say, well, I don't have any HIV because my viral load is negative. You will always have HIV infection. The whole goal of antiretroviral therapy is to keep that viral load count as low as possible, and it is possible for many, many, many years to have an undetectable viral load. That does not mean that you don't have HIV. It just means that it's low enough that the test can't report the actual viral load. If you have HIV antibodies in your blood, you have HIV. Neutropenia and thrombocytopenia may also be seen initially, but that can be from the virus. That can also be from drug therapy. So you may see neutropenia, thrombocytopenia early on as just a acute early infection, or it may be later on you're seeing neutropenia and thrombocytopenia as a result of secondary infection or from drug therapy. Okay, so early on, what happens is you have this sort of acute early infection, and it looks a lot like and feels a lot like the flu, right? Symptoms of early acute infection or seroconversion frequently feel like flu-like symptoms. If you think about any natural immune response to a virus, you have fever, malaise, you might have some lymphadenopathy, you might get a sore throat, you might have a headache, you might have joint and muscle aches, and that usually occurs within 2 to 4 weeks after your initial exposure, just like you have a viral illness, a typical viral illness. So people think they have the flu, they may think they have mononucleosis, they may even come to seek treatment and you treat them for the flu or mono. And you never really ask about, their possibility of HIV transmission. But many people don't seek treatment because they just simply think they have the flu. And we miss a lot of early diagnosis if we don't ask the right questions. So, especially when it comes to people who engage in risky behavior. So, you can still transmit the virus during that early time or that early infection when you really don't know that you have HIV. Then the median interval, so what will happen is that viral load will drop, and then the median interval between untreated HIV and actual diagnosis of AIDS is usually 10 to 12 years, okay? So so this is a time when, education is so important, is that people can be asymptomatic for, 10, for 8 years, 5 years, 6 years, 8 years, 10 years. It can really be asymptomatic because those viral loads are low, and it's not until their CD4 count drops below 500 that they start to become symptomatic. So all these many, many years, you can be transmitting the virus, which is why it's really, really important for us and for healthcare workers to really educate patients on their risk-taking behavior, okay? So you can have chronic HIV infection as well. So you have like an early chronic followed by sort of an intermediate chronic, right? So early chronic HIV, you have a very low viral load count, and your CD4 counts are typically greater than 500, right? So you may be asymptomatic, although patients will frequently complain of fatigue, and they'll complain of sort of low-grade fevers off and on, and night sweats, but they're not enough to cause disruption in your day, so you might not really even think that anything is happening. You might have patients complain of night sweats and sort of generalized lymphadenopathy, but people are really maybe unaware that they have HIV, and this is where it becomes a public health issue, as many people will just go about their business and they continue to transmit the virus, even if they're engaging in unprotected sex or risky behavior, because they just don't think anything about it. That will progress to an intermediate chronic HIV infection, and that is when your CD4 count cells drop below 500. As your CD4 count drops below 500, your viral load will start to increase. And it does that because your body just cannot make T cells anymore. It can't keep up with the rate of loss anymore. And so the viral load will begin to take over those T cells and grow as your CD4 count comes down. So you'll start to see signs of early stage disease. So all of those early symptoms that the patient may have had, like fatigue and night sweats, now those symptoms are more persistent. So the patient's fatigue may start to interfere with their daily activities. You may see a persistent fever. Instead of a simple night sweat, the patient may complain of a frequent drenching of night sweats. They start to have more recurrent headache. They start to have chronic diarrhea. So just basically all of those early symptoms tend to become worse. You may also start to see opportunistic infections begin to appear, and this is a sign that your disease, that the HIV disease is progressing, okay? So the most common infection that the patient with chronic HIV will see is thrush. Thrush is caused by Candida, which is a fungus. Usually not a problem. Candida is usually not a problem in healthy adults, but in this population, it almost always occurs. So thrush is one of the first things that you might see as an opportunistic infection in patient, and that may start to have them seek treatment. You may also have patients present with shingles. So anything that you were ever exposed to early on that your body has been able to sort of keep at bay, now as your CD4 counts fall and you're you become immune compromised, all of these other opportunistic viruses and bugs and things that you have been exposed to sort of rear their ugly heads, so to speak. So aside from Candida, you can also have vaginal candidiasis. Herpes outbreaks are very common. The herpes virus, again, a virus we're probably exposed to a lot, but our bodies can deal with it. When you are immune compromised, you might see herpes outbreaks. You can also see shingles in patients. So those patients who had varicella as a child, chickenpox as a child, may now have a reoccurrence of the varicella zoster, and you may see shingles in patients, okay? So here you see a couple of things that sort of tell you that your patient is sort of progressing to a more chronic late-stage HIV or early AIDS. One of those is Kaposi's sarcoma, which you see in the upper left-hand corner here. Kaposi's sarcoma is actually caused by the herpes virus 8, and these are vascular lesions that you can see on the patient, and they can occur anywhere in the body, okay? You also can see oral hairy leukoplakia. Oral hairy leukoplakia is actually painless for the patient, but you get these white patches on the side of the tongue. Oral hairy leukoplakia is caused by the Epstein-Barr virus, which is the same virus that causes mono. And so these two things in particular are signs of advancing disease. You see here thrush down in the lower left-hand corner, and shingles, of course, very painful for the patient. Shingles, usually the outbreak is along a nerve transmission route, so you might see them on the back or the flank. You may also see them on the face and along the facial nerve. So they do usually follow a pattern along a nerve, and they are extremely hard to get rid of, and they are extremely painful for patients. So AIDS is really considered a late chronic HIV or AIDS. The diagnosis of AIDS actually can't be officially made until the patient's CD4 count is less than 200. So once the CD4 count is less than 200 and they have some of these other symptoms, they can be officially diagnosed with AIDS. So you get a CD4 count less than 200, you look at the patient and they have signs of wasting syndrome where they've lost around 10% of their ideal body weight. So they have obvious wasting syndrome, they look very cachectic, and they have one or more opportunistic infections. So they may have a fungal infection where you see candidiasis, you may see pneumocystis pneumonia. Pneumocystis is actually something that is pretty common. Pneumocystis is a fungus, it's found sort of everywhere, and we probably all have it in our lungs, but our bodies are immune competent, so we can deal with it. But once we're immune compromised, sort of we manifest this pneumocystis pneumonia. Histoplasmosis is another fungal infection that you may see in patients. Histoplasmosis is a fungus that's found in the soil. You may see viral infections in the patient, viral infections especially due to the herpes viruses. You can see protozoal infections as well. Not uncommon to see toxoplasmosis in the patient. So toxoplasma, the parasite that is found in cat feces and rats, you can ingest that and wind up with toxoplasmosis. You can also see intestinal cryptosporidosis, which that is a protozoa that's found in water, infected water. And there are other bacterial infections that you can see. One that you may see is recurrent pneumonia in patients, but they may also have an occurrence of TB. So the Mycobacterium tuberculosis, Mycobacterium infection causing tuberculosis, these patients may manifest that as well. So they wind up with an opportunistic infection, and then the fourth thing that helps diagnose AIDS is actually the sign of a cancer. So they also have some kind of invasive cancer, like cervical cancer. Kaposi's sarcoma can turn into cancer as well. You may see Burkitt's lymphoma, which is caused by the Epstein-Barr virus, but it may transform cells in the lymph nodes into cancerous cells, and you can see also that can lead to an AIDS dementia complex where the patient is very forgetful and they basically have, brain atrophy and signs of dementia. So it's not unusual for malignancies to occur in patients because as, basic immune cells die off, normal cells will go through, just a physiologic apoptosis. And then what happens is new undifferentiated cells begin to grow. Well, these new undifferentiated cells are very vulnerable, and they essentially become cancer cells because there's really nothing to stop them from multiplying, and they wind up causing a variety of cancers that you wouldn't normally see in healthy patients. So what is the nurse's responsibility in caring for patients with HIV? Well, I can tell you that really it's not just the nurse. Caring for patients with HIV and AIDS is really a collaborative effort. It really takes an entire team to help manage the patient with HIV effectively. So healthcare workers like nurses, physicians, but also physical therapy, occupational therapy, case management, spiritual care is really important. Family and friends need to be involved in helping to support the the patient. Pharmacy can help with, monitoring, social work. Those are all important people. And so when patients are discharged, especially from the hospital with new HIV infection, it's really, really important that case management is involved with these patients, because they are going to require lifelong support for this disease for as long as they're alive. So part of what nursing will do, though, is help monitor HIV disease progression and basically immune function. We have a role in initiating and monitoring ART therapy. So part of, if the physician is going to start administering ART therapy, it's going to be our responsibility to make sure that we help really educate the patient on how to take their antiretrovirals. Prevention of opportunistic infections is very important, and having not only in the hospital but also in patient education when they leave, managing and controlling symptoms and preventing complications, and then preventing further transmission of HIV. So a lot of education goes into helping these patients to prevent further transmission of HIV. So part, again, I said monitoring HIV disease progression and immune function is very, very important. Nursing, planning for really nursing care depends on the stage of the patient's disease, right? There's going to be early assessment and interventions that are going to be done that are different when you're talking about late stages of disease. So it all depends on where in the sort of course of the patient's HIV infection you are encountering them, because their needs are going to be different at the beginning, in the middle, and then at the end of their life. They're going to have very different needs from nursing care, But early on, monitoring disease progression and immune function is very important. So, if it's early on in their disease, you're going to be doing HIV antibody testing. You're going to see those results. You're going to be looking at a CBC, or a complete blood count, right? You're going to want to know, are they neutropenic or leukopenic, and are thrombocytopenic, right? Because there has to be monitoring of those counts. You're going to see a viral load and a CD4 count. You're going to want to know what that CD4 count is, right? Because your expectation is that if it's less than 500, you're concerned about opportunistic infection, right? And establishing for the baseline for the patient at the time of diagnosis. So if you're meeting them for the first time and they're just being diagnosed with HIV, have they seroconverted? What is their viral load? What does their baseline CBC look like? If they're anemic, they're going to require treatment of their anemia. If they have a low platelet count, they're going to require treatment of that low platelet count, and obviously, looking at bruising and bleeding prevention. If they're neutropenic, we have infection prevention to deal with. So it really all depends on at what stage you're meeting the patient, because your assessment and intervention is going to be different for each of these stages. And really looking for, are there signs of progression of their disease? We need to make sure that patients have had all their vaccines, so it's really, really important to look at their immunization history and maybe potentially vaccinate the patient so they don't get the flu, so they don't get, pneumonia, things like that. And they need a lot of education about their disease itself and what the expectation is going to be. So really education about the disease spectrum, what their life is going to look like for the next, however long it is, whether it's 5 years, 10 years, 12 years, 20 years, we really don't know how they're going to respond to ART therapy. So it really, a lot of education goes in. People hear they have HIV and they automatically think they're going to die right away. But we know that there are patients living with a very chronic HIV infection for a very long time, right? As long as, keeping their viral loads down, they may respond very well to that. And we don't know what that's going to look like, in a year or 2 years or 3 years. So we do have a role in antiretroviral therapy. So the goals of drug therapy are really simple. They're really to decrease the viral load to as low as possible and to maintain or raise CD4 counts, right? So if my CD4 count is 800, I want to keep it 800 as long as possible. I also, if it's less than 500, would like to initiate ART therapy to see if I can raise CD4 counts, okay? So I want to either maintain or raise them, and I want to delay the onset of HIV-related symptoms and opportunistic infections. So by using antiretroviral therapy, hopefully we can keep keep the patient in an intermediate HIV infection and hopefully put off any kind of AIDS, HIV-related symptoms, or opportunistic infections. And we do that by combination therapy. That is the most effective way, and combination ART therapy really involves 3 or more different antiretrovirals, right? So with monotherapy, drug resistance occurs very quickly with monotherapy. So we typically, pharmacists will use, or physicians will use, 3 different classes of antiretrovirals to give the patient the best chance of decreasing that viral load. And so when taken correctly, if you take the ART correctly, you can actually reduce your viral load by 99%. But that requires a lot of teaching, and it also requires a lot of support for the patient, okay? So on page 248, table 15-13, you're going to see a list of drugs that are used to treat HIV. AZT is still a mainstay of treatment. You're going to see that being used. So there are drugs that will inhibit the actual HIV virus. So it actually, AZT works by inhibiting the reverse transcriptase so that the HIV cannot develop DNA. And there's a lot of drugs that work in different fashions. There's meds that prevent binding of HIV to cells. There's meds that prevent it from entering the host. There's meds that stop HIV proteins from budding so that, it won't attach to cells. There's some that mess up the HIV virus's ability to actually get into the DNA, into host cells. So there's a variety of different medications, and they work in just all kinds of different ways. And here are just some of them that you may be familiar with or may see as you're caring for patients. But again, you should be ready to look at a 3-drug cocktail for patients and teach them about that. There's certainly guidelines about when to start ART therapy. It's usually based essentially on the degree of immunosuppression and what the patient's CD4 count is at the time. It is very, very important to know if the patient is actually ready to do the work to take these medications, because patients have to be ready to sort of walk this journey of lifelong ART therapy. Compliance is absolutely necessary for it to be effective. It's a huge commitment. We know that if they can be compliant, it is 99% effective in reducing those viral loads. But what happens many, many times is it's exhausting to have to do this day in and day out for the rest of your life. So people will do really well for a year or 2, or maybe even 3, but then after a while, people get older, their support systems change, and it gets harder and harder to sort of maintain this high level of compliance. These medications also have a ton of side effects, so they may potentially cause more harm if they're combined with other therapies as well. So you see a lot of patients who will take over-the-counter supplements and a lot of herbal therapies, but those actually will make the side effects worse and can cause potential harm. So a lot of education goes into it, and scheduling is extremely important. Some of these meds have to be taken on an empty stomach, some have to be taken within 2 hours of eating, some have to be taken in the morning, some at night. So scheduling is a huge factor in compliance. Anytime that there's a change in the patient's symptoms, they must report them immediately, because one of the things that we have to know is this a symptom of the medication, or is it a side effect of the medication, or is this HIV related? So things like dehydration, lethargy, vision changes, bleeding, those are all side effects of the med, but those also can be HIV-related complications. So every time there's a change in the patient, they need to report it. All of these drugs cause some toxicity in the body to both the hematologic system, and many cause hepatotoxicity as well. So the patient is going to need their labs checked every few months, and that means they're going to have their CBC checked to look for any hematologic destruction. They're going to look at viral loads to see if it's working. We're going to check your CD4 count to see if your CD4 counts are stable, and then also you're going to have liver enzymes drawn. So the patient is going to have those 4 things done every couple of months during their ART therapy. So again, teaching is going to be really important. Patients cannot stop these medications. They can't take some and not take the others. They have to take it exactly the way it's prescribed. So a lot of times a team approach is very helpful for these patients, and so when you are discharging patients, their families and their support system should also be involved in the teaching about the importance of taking the HIV medications. This is a simple clock that you may see. A clock can be somewhat very helpful for patients so they know when to take their medications, but you can see, here's your breakfast. You can see here's all the meds you're going to be taking today and how many you're going to take. So this patient takes, 12 pills a day. With breakfast, they're going to, 1 hour before breakfast, they're going to take, their Imdinavir, 2 of those capsules. And then at breakfast, they're going to take a whole bunch of these other drugs. And then with lunch, they're going to take this DDC, 1 tablet, and then, 2 hours either after lunch, probably they're going to take these 10 pills down here. 6 200 milligram capsules of Sequinavir and 400 milligram tablets of, Delavirdine, whatever that is. So, again, this is your drug cocktail for your day. So it's an enormous, enormous amount of medications. But a clock can be helpful, in helping the patient. And pregnant moms down here will take AZT. That's what we use for anyone who's pregnant, and they take AZT 5 times a day. So they have to really, making it an actual schedule for themselves and sticking to that routine can be very, very helpful because you have to take a lot of it. So managing symptoms and preventing opportunistic infections and complications is another part of our nursing care, and assessment is a really big part of not only just providing care for patients, but assessment is going to be of symptoms is really important. And the thing about HIV and AIDS is that really your assessment touches on every single functional health pattern that you can think of. So every functional health pattern that you learned in fundamentals, you are going to assess this patient, right? So if you think about, health management, well, do they still have risk-taking behaviors? Are they still risking transmission of this HIV to others? Are they self-medicating inappropriately? Are they using alcohol or drugs to self-medicate? Are they adhering to their medication schedule? If you're looking at nutrition, you're looking at, weight loss, anorexia. Do they have ulcerations in the mouth? A lot of times thrush can cause you to not want to eat anything. It changes the way food tastes. So, weight loss can be a big problem with these patients. Elimination is an issue. Are they stooling frequently? Do they have signs of a urine infection because they're immunocompromised? Fatigue, muscle weakness goes into activity exercise. Do they have night sweats? Are they sleeping well? They need to have a good sleep every night. Are they in pain? Are they confused or forgetful? Are families saying that there's personality changes in the patient? Those may be signs that you have a progression of your disease. Role relationship is a huge functional health pattern to deal with. Is their support system viable? Do they still have a support system? Are they financial issues that's keeping them from, getting medications? Sexuality is an issue as well. Do they have unsafe sex practices? Are they using birth control? If there's genital lesions like from herpes, you can pass those on to other people as well, not just the HIV. And then coping and stress, how are they managing their stress? What is their self-concept like? So when you think about all of your health patterns, you do have to, you are going to really look at every single one and touch on every single one. All your assessment findings can actually be found on page 249, I think. So there's a huge list of things that you would assess your patient for. But the earlier symptoms are recognized, the earlier treatment can be started, and that can help slow the progression of the disease, and that's really the whole goal. We also want to limit the patient's disability as well, and we want to keep them active and moving. So that's a really big factor. Physical therapy is a huge help in this instance. So physical therapy referrals can be really, really helpful for the patient. That can help prevent muscle weakness and wasting, and really it just promotes general health and wellness. They need to get lots of rest, and then they should go see a physical therapist almost every day or 3 times a week at least, and that can help. It's just another added support for the patient. They need counseling. They should get help if they need it. Counseling can provide really good mental hygiene for the patient. It helps reduce their stress. It helps them deal with any issues that they're having. Remember, there is a grieving process that goes into this, right? You are going to be grieving the loss of a healthy life because now you have this chronic infection that has no cure, right? So there's a lot of anger that goes into probably a diagnosis of HIV as well. So counseling can really be helpful. Nutritional support is very important as well. Again, maintaining lean body mass. They really need calories. They need vitamins and nutrients and trace elements. So they need to make sure that their appetite is good. If they are not eating, appetite stimulants are something that can be helpful for the patient. So if you're finding that your patient is just not eating in the hospital, and it's not because they don't like the food, it's just that they can't taste it or they don't want it, appetite stimulants can be helpful. Also, nausea. We really need to make sure that we control their nausea so that they can eat. They should get vaccinated. Their vaccinations are really, really important. Flu vaccine, shingles, varicella, pneumovax, all important in preventing complications. Patient teaching, we're going to teach patient on not only all these topics, but also on the prevention of the disease itself. So patient teaching, lots of education and teaching goes in with these patients. And then also end of life. We have to discuss end of life issues with the patient. Patients have to come to terms with this. You can live with HIV for a really long time, but it's going to eventually progress, and they will find there will be a time when they are facing end-of-life issues. So the earlier that they have their healthcare proxies set in place and their establish their living wills and durable power of attorneys and everything, that is important for them. Okay. Preventing further transmission is a big part of the education process that's going to go into living with HIV. So part of living with HIV is to prevent transmission. And so education is really going to go around, surround a lot of things. One is decreasing the risk of transmission related to risky sexual behavior. Abstinence is the most effective treatment or way to prevent transmission of HIV, but there's lots of ways that risks can be reduced. So as the nurse, you need to get really comfortable with this topic because people need really good teaching. And it's more than just, the sex talk that you might have with a teenager or your child or your kid. It's more than just, make sure you use a condom before you, do anything, because people just don't know what they don't know. They don't know that safe sex practice really means that you have to limit all sexual activity where your parts are going to come in contact with semen or other body fluids. That means, oral sex, vaginal sex, rectal transmission can occur. So you really have to be somewhat explicit on occasion. Compliance is a really big issue in this department. So a lot of times HIV counselors can be really helpful because they really can take the time to teach the patients how to really reduce their risk of transmission. Not always a lot of compliance with this kind of stuff, so from the patient side. So, that's why it's really important to help patients understand what barriers they really need when they're talking about, insertive sex. Are they using them properly? People don't realize that you can still come in contact with, semen and vaginal secretions, and you're still using what you think is a protective device. So really important for that. And then also not just sex, but risky behaviors includes drug use as well. So you do need to reduce the risks of related to drug use. And it's more than just don't use drugs, they're bad for you. We need to be very explicit on not sharing needles, drug paraphernalia. That includes needles, syringes, cookers, snorting straws, rinse water, anything that they can use that they may be sharing. And also, I can't stress the importance of not having sex with people while you're under the influence of drugs or alcohol, right? Because that can really impair your judgment. So knowing where needle exchange programs are in your community is really helpful for people. Every community has needle exchange programs now, so people really should be disposing of their needles appropriately. If they're using equipment that's reusable, equipment really needs to be cleaned and sterilized after every use, right? And this really goes for counseling for patients who are not HIV positive yet, but are engaging in risky behavior. So as a nurse, you're going to see these people in your emergency rooms or your clinics. They're going to come in with other STDs, or they're going to come in with cellulitis or abscesses from needle infections. And so it's a really good time to have this talk about HIV and what this and what reduction of risky behavior really is. There's also, you have to consider decreasing the risk of fetal transmission as well. So pregnancy counseling is really needed, and family planning and birth control measures are important. We do talk to moms if they're HIV and pregnant, then transmission can be reduced by proper ART therapy. And so now moms and moms-to-be HIV discussions and testing is offered to everyone. Prevention of HIV transmission in healthcare workers. We need to take precautions with every patient. Needle sticks, splashing of blood or fluid in your eyes or mouth. We get fluids on our skin. Those can be, all ways that there can be transmission of bacteria and viruses. Transmission of HIV from needle stick injuries, again, are less than 0.3%. We actually get hepatitis more than we get HIV infection. But if you are exposed to a needle stick, don't wait to get treatment. What you need to do is wash the area thoroughly with soap and hot water. We need to notify your supervisor or your clinical instructor if you're in school, and then what will happen is you'll go to the emergency room or you'll go to employee health depending on the time of day. And you will most likely be tested for HIV antibodies, and you'll have a CBC drawn, and then you will be offered ART combination therapy. So combination ART therapy is recommended within 72 hours of exposure, and you will take the combination ART therapy for 28 days. It is not something that you would just accept lightly, so you do want to think about it. There are lots of side effects to the medications, but certainly, taking it for 30 days has shown to be effective in reducing the transmission. And then, older practices such as milking the area that you were stuck or trying to bleed out the puncture site are not recommended by the CDC anymore. Still very controversial to do that, although you will see people doing it. But again, don't wait if you are exposed. Do seek treatment within that 72 hours, so that if you decide you do want to take the ART therapy, the earlier you start it, the better, the less risk, the decrease in risk of transmission. And that is